So at the end of the modules, what would you learn? So what you will definitely learn in the basic module is, number one, how to do the transthoracic echo. That for sure you will learn, and you will understand that this is a standard echo test, and it gives an information like X-ray and more information than X-ray, but with no radiation. So this is the beauty of this test, that it gives you far more information than an X-ray, but without any radiation. Then there is also a possibility, as I already discussed, sometimes the back structures of the heart, which you cannot see well from transthoracic echo, you can do a transesophageal echo. Then for patients, if you want to decide whether this person requires angiography or not, then there is a modality called stress echocardiography. So you will learn how to do the stress echocardiography, whether it is exercise stress test or whether it is a drug stress test like dopamine echocardiography. That much you will learn. Then you will have some idea of fetal echocardiography. When the baby is not even born but inside mother's womb, there are some tests that can echocardiography tests can diagnose certain conditions where you might know that the child is not going to live long, and you might think of abortion even. So fetal echocardiography is very important. Also to look at the uh, well-being of the baby, you can look at the heart. Then of course you can learn 3D, three-dimensional echocardiography, contrast echocardiography. You can do tissue characterization based on the quantification of back-scattered signals. You can do speckle tracking echocardiography, which is now the state of art, or which has now become for myocardial function assessment. It has become a very important investigation. Then there is something called digital echocardiography, where the echo images can be stored on videotapes. Then there is something which has come up recently, is even handheld echocardiography, which is a small cell phone like device which connected to the probe can give you echo pictures even on your cell phone kind of device. And this you will see once you go through this whole module. Then, as I already said, two broad things that you will learn is how to look at the structure and how to look at function. In the structures, you could look at pericardium, you could look at ventricle, whether right or left, you could look at heart valves, great vessels, you could make a diagnosis of traumatic heart disease, you could look at impact of hypertension on heart, you can look at even pulmonary diseases, some rhythm disorders, and some neurological diseases. So these, how the heart looks on echo in these conditions, this you will learn. And then also you will learn it how some of the structures function, whether they are normal function or abnormal functions, like stenosis or regurgitation of valves, like how you to calculate blood flow through the heart, and in that way indirectly non-invasively measure the cardiac output. And also you can learn about the systolic and diastolic functions of the heart. So currently, where is echo used in clinical practice? So for a cardiologist or in a clinical practice, where they are used, of course, number one is assessment of left ventricular function, especially when somebody has got a coronary artery disease. There is something that you can look at as wall motion abnormality, and through the wall motion abnormality, you can make an idea whether this person is suffering from a coronary artery disease. Even some cases you can tell that this person has developed heart attack or myocardial infarction. Plus, of course, you could look at murmurs, whether they originate from mitral valve, aortic valve, tricuspid valve, or pulmonary valve. And also you could look at these valves and make various diagnoses, as I already discussed. In some kind of arrhythmias, especially atrial fibrillation, echocardiography is used very frequently to detect the cause of atrial fibrillation, whether it is related to valve disease. Okay. So it can also be used in case of electrophysiological abnormalities or arrhythmic diseases, particularly atrial fibrillation, where what it can tell you is what is the cause of atrial fibrillation, whether it is valve disease, whether it is coronary disease, whether it is cardiomyopathy, what is the reason for the atrial fibrillation, that you can find. You can even look at the underlying problems, and this can help you guide therapy in atrial fibrillation. So this is something that you can do. Then in cases of strokes or transient ischemic attacks, it can tell you whether these strokes originate from some thrombus inside the heart, and the echo is very important to tell you that whether there is thrombus, also whether there is a patent foramen ovale that is responsible for some clots coming from right to left side and so on. Then of course any infections of the heart like infective endocarditis, it can be very useful. Assessment of artificial valves. So once valves are done, then this is a whole new field for echocardiography. You could do echocardiography, and it is the actually investigation of choice, or at least one very important investigation in diagnosing if any problem has happened in the artificial valves that have been given, whether it is a surgical valve or it's a transcutaneous valve. So any problem in these artificial valves can be picked up nicely by the echo. Now coming to, these were more for cardiologists, but where can physicians or where can a common doctor or ordinary doctor use echo? So a common doctor uses echo in emergency room, in ICUs, in wards, and of course in labs it is used, that all of us know. What are the conditions, common conditions for a physician where echo will be useful? Now I have come to the part of non-cardiologist. Where can a non-cardiologist or a physician use the echo in clinical practice, in his day-to-day clinical practice? So these are some of the places where a general physician can use echo to help him in his day-to-day practice. One, chest pain, shortness of breath, syncope, dizziness, whenever there is a suspicion of any source of embolism, when there are palpitations, when ECG is abnormal, echo might be useful. When there are any murmurs or clicks, then echo may be useful. And in any symptomatic patient where you want to screen, even if the patient is not having symptom, but you want to look at the heart, whether he is harboring some heart disease which has not produced any symptoms, even there you can do echo. So coming to, of course, chest pain, this is the most common reason for using a echocardiography, and in many cases of chest pain, especially heart attack or acute coronary syndrome, it can be very important, and there is something called wall motion abnormalities that can be picked up, and they can confirm the presence of a coronary artery disease. And in heart attacks, when there is a gross heart attack, it can be actually the most effective investigation. It can tell you where the heart attack has happened and how much part is infarcted. Even that you can make out much better than a ECG. So echo can be very useful in heart attack situations. Also, once these heart attack patients come for re-evaluation, or once these acute coronary syndrome patients come for re-evaluation, then you can look at the serially follow the ventricular function, whether it is improving or dropping. And even more important, it can be useful when you want to rule out some other conditions which very closely mimic a heart attack. So there can be many situations like aortic dissection, which clinically may mimic a heart attack. And so this test can very nicely rule out a heart attack and make a diagnosis of these kind of diseases like aortic dissection, valve diseases, pulmonary embolism, and even pericarditis. So these are some of the things where patient comes with chest pain, and you are not very sure whether this chest pain is because of heart disease or not heart disease. You do an echocardiography, ECG, and in ECG also you are not very sure whether it is a heart disease or coronary heart disease or some other disease. Here echo will be very useful because it can tell you whether it is this chest pain is because of coronary artery disease or whether this pain is because of let us say aortic dissection or aortic disease, whether it is because of valvular disease, whether it is because of pulmonary disease, or whether it is because of pericardial disease. So all those things echo will very nicely show you. So that is why I'm saying it is very important even for physician, because physicians are sitting in the casualty and they often see patient with chest pain, and often it is not very diagnostic. Even they do ECG, still not very sure. Then echo is the to go investigation for this kind of situation. Another common symptom that physicians see is shortness of breath, and actually it is one of the most commonest symptoms in a casualty wherever a physician is sitting. Now, what echo can do is it can differentiate between heart disease, lung disease, anemia, even obesity and deconditioning. So it can clearly tell you that okay, this breathless shortness of breath is because of heart problem. And especially if it is related to heart failure, then echo can do a lot of things in making a diagnosis of heart failure, in knowing how much heart failure has happened, looking at the chamber volumes, the systolic functions, diastolic functions, and heart thickness. Even it can help in the finding the cause of heart failure, whether it is because of coronary artery disease, whether it is because of valvular heart disease, whether it is because of prior heart attack, or whether it is because of some other cause of cardiomyopathy. And it can even tell you whether the heart failure is with low ejection fraction, preserved ejection fraction, or mid-range ejection fraction, and even look at the diastolic function. So for a shortness of breath patient, practically it is an investigation of choice, especially if cardiology problems are high on list. Then other than this also, patients who are receiving chemotherapy, then often many chemotherapy drugs called decrease in the cardiac chamber functions or ventricular functions, and so therefore these patients may serially require echocardiography to pick up whether this dysfunction has started happening, and therefore have to modify the chemotherapeutic agent. In acute respiratory failure, it can rule out heart diseases. When right ventricular function is affected, it can echo can find out the cause of right ventricular dysfunction, make a diagnosis of right ventricular dysfunction, find out cause of right ventricular dysfunction, especially if it is because of embolism, because their echocardiography will be very useful. Even in chronic pulmonary disease, it can, with acute deterioration, it can tell you whether it is because of some heart problem that is causing, or it is just right ventricular failure because of cor pulmonale. Then one another investigation or indication where it is very useful is case of any arrhythmias, any syncope or dizziness, and there, you know, if you can find a source of embolism, then it will be very important. But otherwise what you can see is you can find out whether this arrhythmic disease is because of vasovagal or orthostatic hypotension, whether it is because of arrhythmia, whether it is because of cardiac structural abnormality, or whether it's because of neurological causes, and make some diagnosis in case it is a heart structure problem, whether it is aortic stenosis, whether it is hypertrophic cardiomyopathy, whether it is a case of left ventricular dysfunction, whether it is case of intracardiac tumor, or whether it is because of pericardial effusions. So this all you can make. And then, as I said, if there is a stroke, there is a cardiac source of embolism, then what it can do is look at the patent foramen ovale, whether there is a right to left shunt, whether there is a septal aneurysm that is responsible for this kind of thing, and also whether there is an infective endocarditis and which is throwing the infective emboli. Now, the third important reason why you would, or fourth important reason why a general physician should know echocardiography is because they can evaluate case of palpitations or abnormal ECGs. So basically what they can do is, in a patient with palpitations, of course, history and clinical examination, even Holter is very important, ECG is very important. But besides that, if there are frequent ventricular VPCs or AF or SVT or VT, then echo is mandatory. So in these four cases, frequent VPCs, of course, if the number of VPCs are low, you may not require it. But if there are frequent VPCs, if there is AF, if there is supraventricular tachycardia, ventricular tachycardia, echo is practically mandatory. Also, if there is abnormal ECG, if there is a RBB, then you can do echo, especially if you think RBB is because of some cardiac problem. You can do echo to find out the cause of RBB, whether it is pulmonary embolism, whether it is atrial septal defect, whether it's obstructive sleep apnea, or whether it is pulmonary disease. On the other hand, for LBB, practically everybody will require echocardiography, because cause of LBB can be hypertension, coronary artery disease, heart failure, myocarditis, valvular heart disease, and cardiomyopathy. All cases where echo is practically mandatory. So here, in case of palpitations, you see that more or less many patients will require echocardiography. Anybody with abnormal ECG more or less will require echocardiography. Then what about murmurs of clicks? As you can imagine, most of these patients will require echocardiography to make a diagnosis of valvular heart disease or any structural heart disease, even congenital heart disease. Although there is a group of patients called innocent murmur where you may not do a echo, but otherwise for all the murmurs and clicks, echo is practically mandatory. Also, if you suspect infective endocarditis, then echo is the only way to look. And as a matter of fact, in some cases, besides transthoracic echo, you might even require a transesophageal echo. And but of course, you should not do echo in all cases of fever, but in those cases of fever where suspicion of heart disease is very high. Then, as I said, asymptomatic patients screening is very important, because many of the diseases, if they happen, they also run in families. Bicuspid valve is one disease. About 1/10 of the people, relatives, will have this disease. So it can be a good idea to look at the echoes of these people, the relatives, if suspicion is high. Another disease is Marfan syndrome, where this penetration is very high, and actually practically you should do echo in all the relatives of Marfan syndrome. And actually, as a matter of fact, even if they have normal echoes, they should be repeated after every 5 years interval, and once they develop a disease, then they have to be done every year. So this is the normal protocol. So then finally, as I said, echo is even useful for non-cardiologists, because it can be a key evaluation tool for diagnosis, prognosis, and even surgical or interventional management of many cardiac conditions which present to the physician. So they come to the physician first and then they go to anybody else. So if they are conversant with this investigation, they can very easily help these patients. Also, as I already discussed earlier, the prevalence of these heart diseases is increasing. Why? Because number one, people are getting older, and as they get old, heart disease develop, especially degenerative heart diseases can develop. Also, number two, because many people are surviving their heart problems or heart attacks, and then they come into chronic heart failure and they continue for long time. So that is why number of heart patients is increasing. So physicians will encounter one day or other. As a matter of fact, it has been found that many heart patients present first to general physicians as their first point of care. And it is estimated that even coronary artery disease, about let us say 1 in 6 or 7 patients present to the general physician, so general practitioner. So these people, if they can do echo or they can understand echo, is always a very good idea, because this is where the patients are presenting. And it has also been found that even heart failure, low risk heart failure, can be very nicely managed by general physicians, so they can always do regular echo. So that is why point of care echo is important for GPs to learn this echo. And American College of Cardiology has actually stated that uh, knowing echo and performing echo contributes to improving patients' clinical outcomes, and on the other hand, inappropriate echoes may be harmful. So this knowing when to do echo and when not to do echo, how to do echo, and how to interpret echo is a very important skill, which practically anybody who's practicing as a general practitioner or practicing in emergency should know. So now the question is that suppose the general practitioners learn how to do echo. So how much echo they can learn? What is the qualification with which they can learn the basic echo? And as you can see that while advanced echocardiogram is done by only DM cardiologist, a basic echocardiogram can be performed by any MBBS, MD medicine, or even a technologist. And of course, very advanced echo, even DM cardiologists who are trained or specifically trained for echocardiography, they can do the advanced echocardiography. But let us come back to the basic operator, which any physician or even non-physician can do. So what this basic operator should do is have some training, and this module will impart that kind of training where he will start understanding the cardiovascular structures, functions, and abnormal cardiovascular functions. And not only those, but what are the principles guiding those estimations. So those things they should know. First, they should know how echo works. Second, they should know how to do it. Then third, they should know how to interpret it. And this is the basic operator knowledge that we are trying to impart through this echo course. So if you look at the basic operator and you compare him with an independent interpreter, so means that a DM cardiologist versus other person doing echo. So what anybody can do, learn very easily, is how to do 2D echo, M mode echo, pulse echo, and color Doppler echo. This anybody can do. Of course, for complicated things like contrast studies, strain imaging, 3D, maybe you require a advanced training, and that is there in our advanced module. But basic training will involve these structures that I have already outlined. Advanced training will involve, we already discussed that, contrast echo, strain imaging, 3D echo, that will come in the advanced module. And there are a lot of skills that you would learn with basic course also. And these I have just outlined those skills that you will learn. But on the other hand, on the right side, if you do the advanced course, then these are the skills that you will learn. So of course, what is the value of this course? This course will offer you both knowledge and skill to do echo, to interpret echo via a method of transformative learning. Not a textbook kind of learning, but a transformative learning where you would understand by seeing the images, the cases, and many other things. This will also, I feel, change the attitude of physician towards practice of medicine. So now they will start looking at the medicine, practice of medicine in a different way, anticipating what are the cardiac problems that can be happening to the patients, and quickly assessing them by doing an echo and interpreting a echo thing. So this is the second thing that will happen. And they will also, I feel that people doing this course will understand how rapidly the medicine is changing, and it will, I hope, instill feeling of change and how to accept this change and learn more and more as the medicine is evolving. But at the practical level, what this course will impart is that it will allow you to comfortably do and interpret selective number of echoes. So with this I will end, and thank you so much for joining this course.